All right. Well, hi everyone. My name is Dr. Marino Bucci, and I'm here today to talk to you about the management and assessment of concussion from a sports physical therapist perspective. So let's get into it. So a little bit about me. I graduated from University of Central Florida with my DPT, and then I went on to do a sports medicine residency at the Ohio State University, and then I'm currently at Duke University working sports medicine at Duke. And then just other disclosures, I am a sports medicine endorser slash liaison person for Dymatize. It's a nutrition company. And go ahead and follow me on social media if you want to follow along. Our objectives for today, just want to define concussion, what it actually is, how we assess it, how we can best manage it. And again, this is from the perspective of a sports PT, so I'm sure there are different ways of doing things in the neuro world, but a lot of the concepts overlap between the two specializations as well. So I just wanted to give you my perspective on it, and you can integrate that in with your neuro perspective and how you guys address and manage and treat this as well. So I'm not going to go through all of these, but that is what we're going to be reviewing today. And then I just wanted to provide this. So this is just an example of the evolution of how we manage, treat, and talk about concussions over time. So every couple of years, there is a world group that gets together. There was one in Amsterdam. There was one in Berlin, I believe, is the one before Amsterdam. So this happens regularly, and it's a group of individuals that get together, discuss current research. They collaborate on research too and make systematic reviews at that meeting based on other people's research and determine a whole worldview on how we should start assessing and addressing concussions and just making sure that everybody's on the same page. So the 2022 Amsterdam Consensus meeting developed this definition of the concussion. And so it's a traumatic brain injury caused by a direct blow of the head, neck, or body, resulting in an impulsive force to the brain. And it's often associated with that coup contra coup injury there, where the initial blow is from maybe something hitting your head, and then the subsequent blow could be from your brain actually hitting the inside of your skull. And then just some details here. I'm not going to review each one of these, but I just want you to understand that this affects a lot of people. It's a really important issue, and we're still learning how to best manage, treat, and assess it. So what actually is happening with the concussion? So the neurophysiological differences that we see with concussion can vary from one case to another, but oftentimes our regulations on how much of a neurotransmitter to produce or how much not to produce, or even hormones or other compounds in our body, we just get out of whack. So sometimes we're producing too much of something, or sometimes we're not producing enough of something, or sometimes our production is adequate, but we're not responding and not producing those things in response to the things that it should be produced by. That'll make a little bit more sense later. But basically, we have, in general, a production of this excitatory neurotransmitter glutamate. And then we have a disruption of the neural membrane and the release of potassium. And then that causes an influx of sodium, which results in axonal dysfunction. So we're going to have a disruption of communication because we have the axonal death, leaving them more vulnerable to injury and affecting things in numerous different ways just because of the inability to communicate effectively to other systems. We want to restore cerebral homeostasis and ensure that everything is not only pumping out the way that it needs to and responding the way that it needs to, but it's doing so with adequate amounts of whatever compound or material needs to be produced at that time. So there's a lot happening. Again, this is a generalized kind of neurophysiological reasoning. There are different things at play as well with different cases, but I just want you to understand that there are true neurological things that are happening, and this is one of those primary mechanisms. From there, we have things called second impact syndrome, and this is basically like if we were to return an athlete or an individual a little bit too soon after their concussion, and they have a chance of receiving another second impact. So this is relatively rare, fortunately, hopefully because we're returning people with adequate amount of time to heal up. If you have a situation like we saw in the NFL where a player got knocked out or almost unconscious, and then they actually returned him back that game and had a second extremely severe concussion. That's not necessarily saying that they had second impact syndrome, but those are the types of situations that we're talking about with this. When we return an athlete too soon, or we just don't follow the steps that we need to, and then they get back out and play, and then they get hit again, it's extremely, extremely dangerous. Another reason to emphasize precaution, and that we're not in a rush to get these athletes back out there or these individuals back out to whatever they're doing. It's really important that we let their brains heal up. And then another thing I wanted to mention, because becoming a little bit more popularized now, is this chronic traumatic encephalopathy, so CTE. And so this is a progressive and fatal brain disease associated with repeated blows to the head. It's also associated with dementia and some other psychiatric disorders. So you can't really diagnose this until autopsy or postmortem. So we want to be aware of this. But there is a shift in the language of the diagnosis. So rather than calling it CTE, we're starting to call it traumatic encephalopathy syndrome, so TES. So just be aware of that. If you see TES, it's most likely similar to CTE. And then oftentimes we'll see some sort of posturing depending on what aspect of their brain, spinal cord, or midbrain, pons, medulla, whatever may be actually affected. We might see different presentation of the athlete. So just know that we can gather some information right out the get-go just by how the athlete is presenting on the field. So preseason and baseline testing, I'm not going to lie, this is something that we all need to do a little bit better on. But there are now 13 R's of concussion. There used to be 11, but they added a couple additional ones. So I'm not going to read all of these, but these are the primary things to consider when it comes to concussion management as a whole. So just know when people talk about the 13 R's, these are the things that they're talking about. And just to highlight a couple of those, reduce the occurrences of sports-related concussions. How can we do that? Here are some mechanisms that we're doing right now. So ensuring that they have a mouth guard, ensuring that they're doing a proper warm-up. There's how to educate other individuals, like other healthcare providers that maybe aren't even healthcare providers, that can help recognize when they're seeing something in their athlete or if they're a little off. So there's a lot we're doing to try to reduce the incidence of concussion. There's new sports rules, but of course they still happen inevitably anyway. So we just want to try to reduce the occurrence as much as we can. From there, we want to remove and recognize. So these are from the 13 R's, and just wanted to highlight this because some of the new consensus statement items were to add a new tool that allows non-healthcare providers to recognize when someone is concussed and then get that individual to a healthcare provider for an actual assessment. But we are really trying to empower others to recognize these things too. So it's just the healthcare providers that can say, hey, that guy looks a little off. Maybe we should have him sit. Because sometimes you don't have any healthcare providers there, or if it's at like a pee-wee game or something and only parents are the providers, we need everyone to be on board and understand what they're looking for. So when it comes to the actual formal assessment, we have this tool called the SCAT-6. There's a SCAT-5, but they just came out with the SCAT-6 with this new Amsterdam consensus statement. And ideally, you want them to be done within 72 hours. Otherwise, there are things out of whack. But the main reason for 72 hours is because we want to get a baseline of where they're at. And so that's why it's so important to do the initial baseline testing before they even start the sport, so that we have something to compare against. But even if you didn't do the baseline testing, at least we have some information right now. All right, the concussion just happened. How did it affect him right in this moment? And then as we progress throughout their healing, we can keep going back to that assessment and ensuring that they're progressing that way. There's another assessment tool for in the office. It's a much more robust, longer form, and that one you can do greater than 72 hours because, again, it has a little bit more detail to it, and you can't really necessarily do it on the sideline, but you'll use that information and compare it against the initial one that you did to help track progress. And then impact concussion testing is another thing that's been done in the past. It's kind of phasing out, or at least becoming integrated into some of these other tools. So if you hear people talking about impact testing, that's just another tool that has been used as well. I'm not going to highlight these anymore. The CRT6 is that concussion recognition tool that I had mentioned earlier, where we're having athletes' parents understand what to look for, or maybe not athletes' parents, just someone who's volunteering in the sideline when there's no other providers there. So there are tools for other people who are non-healthcare providers to recognize some of these symptoms and pull the athlete from play as well. And then we have some additional tools here, and we're going to talk about them a little bit later, but taking mental health into a factor, and then the vestibular motor screening isn't a part of the SCAT-6, but it likely will be in the next one, and we're going to talk about that in a bit. So overview, just very big general overview. We want to have a very systematic and quick assessment. Could be potentially life threatening, so it's got to be relatively quick, but you're still effective enough to capture the information that you want to capture. So you want to have a good system in place, almost not even have to think about what the next step is, because a lot's going to be going on. Sometimes, like on a rugby field, for example, when athletes would go down, they're out there, you're assessing and doing cervical spine assessment while the play is still going on around you. So it's super important. We're in the moment. We're not thinking about, oh, what do I need to be doing next? And we kind of just move right along, right to the next thing. Majority of concussions do resolve in about 2 weeks. However, if they're a little bit younger, or if they're older, or if they have comorbidities, that generally we would see a resolution of symptoms within 14 days, but not all the time. So how do we respond when we see an athlete go down on the field? This is the big general overview, and we're going to dive into these a little bit more in greater detail. But overall, we want to first make sure they're alive. So we want to make sure that they're breathing, that they have circulation, that they can respond to you. Then let's say they are responsive and they're able to kind of give you all the information you need orientation-wise. You would go on to a neurological assessment, evaluating their cervical spine, and then just following these steps. And again, we're going to highlight these as we go. So these red flags were determined as things to look out for. Again, we want to follow that systematic process, but we want to be looking out for these red flags. And if we see any of these red flags, most likely we're going to be calling EMS. So, and just one thing I wanted to note on here is that GCS under 15, max score of a GCS is 15. So it's basically like any negative of the GCS is a red flag. So just be aware that it used to be under 13, I believe, and now it's been moved up to under 15. So just be aware of these red flags to keep looking out for, and you're definitely going to remove them from participation if you see any of these. Quick shout out back to this Canadian C-spine rules. It's important that we keep them in the forefront of our mind because they're not going to go away, and we want to keep note of these. So here is the actual algorithm that was developed during the consensus. They updated the flow, and basically, if you want to take a screenshot of this is kind of the flow that I would follow on the sideline, and I'm going to go into that in greater detail in these next couple slides. But we want to look for observable signs. So signs are going to be those red flags on the previous slide, things like laying motionless, if they're posturing, if they saw an extremely severe collision, and maybe they're not laying motionless or anything, but they're hurting, they're holding their head. Honestly, even if sometimes if you just get hit in the head and you're holding your head and you seem completely fine, you could still have a concussion. So be aware of what happened, how severe was the hit, how are they acting now, and just things that you can just visually see. And then look at the GCS, and we're essentially going to make sure that they're responsive. And from there, once they're responsive, we're going to, and this is still while we're on the field, cradling their head. So just to go back, we're on the field, cradling their head, grabbing the basically their subocciput in your hands. Some individuals like to grab their shoulders and then support your forearms, but you basically just don't want their cervical, you don't want them in cervical extension. So providing a little bit of stability to their neck. And then I usually have them look in my eyes. I'll say, look in my eyes, everything's here, trying to keep them calm. And then I'll go through some of my responsiveness questions at that point. If they are responsive, I will then proceed on to the next part of my assessment. So my hand is still there, and I'm going to just very, very, very gently palpate their cervical spine. The thing you're looking for here is midline tenderness, so on their spinous processes. Everyone is going to say it's sore. Everyone's going to say, yeah, that's a little tender. You're looking for jumping out your seat kind of pain. If you touch a spinous process and they either wince or it's just really not feeling good, or if you palpate any actual deformities, those are all indications that we just need to stop what we're doing, call EMS, stabilize, and get them on the stretcher. It's really important while we're doing that palpation that we're very clear on what we're doing. If you just start poking around in there, they're going to freak out. A lot of this is just trying to keep them calm and being able to get a good assessment while they're not in an excited state. So from there, we're going to say, all right, I would like you to wiggle your toes for me, or can you wiggle your toes, or can you squeeze the individual on the right of you's hand or the individual on the left of you, just to assess their any paresthesias or motor functioning, and you're also going to ask the individual touching their hand, whoever may be around you helping out with the assessment while you're still supporting their head, checking for motor and sensory deficits in the periphery. From there, if everything looks okay, you're still holding their head, I am going to check your active range of motion. I want you to do the motion, you to do the movement, but I'm going to have my hands here and I'm going to support you. So then we're going to go to the right, and so I'll explicitly tell them what direction we're going first, and then they'll rotate their head to the right. You're just guiding them, you're not doing it for them. And then you're going to have them go to the left. And again, you're just guiding them, not doing it for them. If you run into any blocks or any issues or any significant pain with that rotation, again, it's time to transport and immobilize. But if everything looks okay from there, then we could potentially have them sit up, and then we will progress to the sideline for further assessment. Moving on to the sideline exams. And so the SCAT-6 we're going to go through, but this is the thing that we want to try to do right away so that we can get some good info. If I'm out on the field with an athlete and I have someone who can cover the field for me, I will usually take them like inside the training room or somewhere where it's a little bit more quiet for this, so we don't have other variables coming into play. And we're going to go through it together. And so we want to look at their mental status, the history, the symptoms, their neurological exam, kind of their motor control, cognitive function, and then just do a more standardized assessment with questions. So initially, when we are doing this, we're going to look at their mental status and the history of everything initially first. So orientation questions, person, place, location, event. And then Maddox questions are actually going to be a little bit similar to orientation questions, but they're more specific to the event that you're attending. So it'd be like, what was the score when you went down, or what period, or what was the team that we played last week, or do you know what the visiting team's name is? So still orientation-like questions, but it's more specific to the event that you're at or what they just did, just a little bit more specific to the athlete in general. And then we're going to look for signs and symptoms, so all things that we want to look for. Usually if you have 2 or more, that's enough for me to pull them. Sometimes if they just have a headache, I'm still extremely careful on this, but if you just have a headache and literally no other symptoms at all, in sport we get hit in the head occasionally, and sometimes it hurts and it gives us a headache. So sometimes just a headache isn't enough to pull them, but you want to be really cautious with this, because even just one severe symptom could mean they have a concussion. Just know that one symptom alone, some providers might not pull them from play. 2 or more symptoms, they definitely will. With the symptom list that you're going to go through in the SCAT, there's so many different symptoms on there, so it's very rare that you're going to have an individual with just one symptom. And then we're also going to check their blood pressure and their heart rate. Vitals are vital, and so want to make sure that they are not in shock at all, or that they're also responding to exercise. I mean, we're out on the field and exercising pretty intensely, so you should see an elevated blood pressure or potentially an elevated heart rate. If those are significantly low, that might not be the greatest thing, because it's showing that their body is not responding the way that it should to traditional exercise and exertion. So cranial nerve testing, so we're in person. I would have you guys sit down and practice this together. So I'd like you to pause the video and just go through your quick 1-minute cranial nerve screen from start to finish. But it's important that it's really effective and efficient, because sometimes you're in the moment and you have to make a decision to return them right then and there. We want to get pretty efficient at these, and here is just kind of like a little cheat sheet. So you can get like 6, 3, and 4 out of the way just with eye movement. And then there are different strategies for different cranial nerves that you can do to quickly assess a couple of them or kind of combine them together. But yeah, just really important that you practice this. Efficient but effective while doing this. So then we're going to check their motor control, their ability to kind of control their movements and not overshoot or undershoot, and see if we have any tremor, idokokinesia. So coordination tests like essentially flipping their hands over and rapid alternating movements, those rapid alternating, or shin, like rubbing their heel from their shin to their toe. That'll tell us their coordination system, their cerebellar system, at least on their coordination front, be okay. So let's move on to the next thing. We're also going to do a balance assessment as well. And then just to keep on in line with everything, so now that we've gotten a chance to kind of chat and we're on the sideline, things have calmed down, I'll still kind of ask some more questions and about their mental status at this point. And again, I'm checking vitals pretty regularly, about every 5 minutes, just to make sure. We have dysautonomia, which is basically autonomic nervous system kind of getting thrown off, and we might not respond to exercise the way that we should for that. But I'm also looking for just other signs of decline. And sometimes the respiratory rate, heart rate, and blood pressure can give us that information. So it's important that you are checking their vitals and get really good with blood pressure cuffs, because you're not going to have any manual ones on the sideline. And you have to be confident in the readings that you're taking to know whether or not this athlete is declining or if they're staying stable. From there, we have, this is everything we just went through. And then when they come in to see you for treatment, or a couple days later, maybe it's not within 72 hours, there's a formal SCAT-6, which is essentially the same steps, just in a little bit more detail. And so we'll use that to track their progress over time. And I'll do the symptom score every single visit, but I don't know if I'll do the entire SCAT every single time I see them, unless you have the ability to. If you're in a concussion clinic, then you definitely should. I just only get to see my concussion athletes once a week if I'm in the clinic, and then twice a week while I'm in the training room. So it's a little different for how often I get to see them. But it is important that we're continually checking symptoms, because that will be the biggest gauge of how they're doing and whether or not they're progressing or regressing. And so then we have the symptoms evaluation, cognitive assessment. So we're going to ask them orientation, and then this immediate memory list was increased from 5 words to 10. So go ahead and take a look at these words here. And this is just an example of a list of words that you would read off to the athlete and have them repeat back to you, and then you'd score that. And then there's other elements like repeating digits. So you would say 1, 2, 3, and then they would have to repeat it backwards, like 3, 2, 1. And you do that all the way up to 6 digits, and then they have to repeat them back. And the SCAT will give you actual explicit instructions on how to do all this. So I'm just kind of breezing through it just for the sake of time. But just know that the true direction is SCAT-6, and you can type SCAT-6. Then we're going to go to the coordination and balance assessment of the SCAT-6. So we got the balance error scoring system. Just know the modified one is just no foam. The regular one is with the foam. So there's 6 elements to it: feet together, tandem stance, feet up. And then you also can do this with your eyes open or with your eyes closed, depending on how severe it is. If they can't even stand feet together with their eyes open, I'm not going to have them do it with their eyes closed. So it's just ways of challenging them in different methods. So we're closing their eyes is essentially taking out the visual input. Adding the foam is potentially messing with their proprioceptive input. So there's a reason for each of these. I wouldn't continue making it more challenging if they've already done horrible on one step before. So it's another good tool to use and kind of gauge their overall balance. And then this is another one that's not done on the sideline, and so it's just tandem gait. So you're having them walk a 3-meter line, tandem stance, and tandem walking. You're having them do that as fast as they can, and you're taking the time. And then if you want to make it more challenging, let's say they're doing really well and they're like, I need to go back out in the field, I'm ready to do this. Sometimes we have to use some tools to show them, hey, you're actually not ready. And so the dual tasking gait is an additional one where we're going to have them do that same task, but I'm going to give them another task to do while they're doing that. So maybe name all the months of the year in reverse while we're doing this. And so that'll just add some increased cognitive demand and potentially tease out a little bit more of the errors that they may not have with just the tandem gait. And from there, so what we're going to do now is I want you to pause it and tell me the 10 words that you were able to recall from that initial list. And then I'm going to press the button and they will pop back up. So go ahead and try to pause it. See if you can write down how many words that you remember from the initial 10. And 5, 4, 3, 2, here are the words. So hopefully you did well, and hopefully you're not concussed. But we'll take the score overall, and then that'll become their total cumulative score. And we'll use that score as a way of tracking progress over time. And then at the end, the last step is the decision to return them or to start on a return to sport protocol. And they have just an outline on the SCAT-6 on how to do that as well. So a big summary of everything we just went over. We want to determine, is it life-threatening? Checking the orientation. We'll go over to the side. We'll do a larger check of everything. We'll do the cranial nerve screen, balance screen. If we have time, the full scat. And then refer them out to a clinician or an NCS or an MD or another provider who has worked with concussions for further workups if necessary. Super important that during the event you don't just leave them hanging, and it's really important that you make sure that someone that is going to be with them that can kind of remember some of these pieces of information in case the concussed athlete not. Just let them know kind of what to anticipate as far as how long it might take. Limit screen time, but you don't want to completely eliminate screen time. That's a little bit of an update as well. I don't want you to cocoon the athlete, which is essentially like shutting them in a dark room with no stimulation. Like, that's a no-go. Screen time in the world that we live in now, it's impossible to avoid, so a little bit is okay. Just want them to limit that as much as they're able to. And then always changing positions, preventing some cervicogenic issues and some neck pain from occurring. I'll see individuals' posture kind of dwindle as their postural correction muscles maybe aren't working adequately, or their vestibular system maybe isn't telling their postural correction muscles what it needs to do. So changing positions and just being aware of posture is a good thing as well. And then want them to start resuming their ADLs, and so integrate them back into normal tasks. Want them to sleep well, but again, not excessive sleep, so 12 hours plus every night, but they want to make sure they're at least getting their 8 hours of sleep. And one important piece here is avoid alcohol, avoid anti-inflammatories, because it will mask their symptoms. It's important that they're not taking things that can mask their symptoms so that we can track their progress over time as well. But however, if necessary, then they are able to use Tylenol. So again, just kind of reiterating what we just went over. I'm not going to go over this again. You just want to make sure that you include the parents or roommates or whoever in on these conversations as well. So we want to make sure that everyone is aware of what's going on and what to expect and how to address it in the short term. And then ideally you want to get them to an MD or a medical professional so that we can start the recovery and return to activity process. When do we need imaging? So determining the need for imaging is basically if they did lose consciousness and they even have just one of the symptoms on the right, then we need to get them sent for imaging. If they did not lose consciousness, they need 2 or more symptoms on the right, and then that would be indications for imaging. Again, CT is the most commonly used. However, sometimes for some more severe cases, they may use MRI. But just be aware that CT is the most common one with most head injuries, but especially with concussion. And post-injury guidance and rehab, so this is where a lot of us will come into play. So if you're not a sports medicine provider, you're probably not doing a lot of those acute response things. You could still be a part of the assessment. So I have had NCSs on the sideline or a neurospecialist MD on the sideline with me. So I'm out there running out, doing the actual assessment, holding the athlete and making sure that they're stable. But then once we get to the sideline, the NCS or MD may take over for the assessment on the sideline. So even as an NCS or a neuro PT, you still need to know some of these sideline elements that we just went over as well, even if you're not the person running out in the field. But you definitely need to know what we're about to talk about, because if they do come to see you in the clinic, this is kind of your time to shine. So their initial symptoms is going to be the best indicator of how long this is going to be recovery-wise. There's a lot of things that are occurring with our brain function in the recovery after the injury. So the behavior changes that we are seeing in the patient are not just them being irritated at us. It could be because of actual recovery that they're going through. Of course, it's a frustrating and anxious and scary situation anyway. Also, we are adding on top of that the fact that their brain has been damaged and it is healing up. So super important that we're patient with these individuals and that we're looking out for personality changes, and we're not taking any of those personality changes personally, but we can take note of them and use them as a way to, again, measure their progress over time if we stop seeing some of these changes that we're seeing currently. So again, rehabilitation typically will begin a couple days further out. Not every provider is going to send them to a PT to continue doing treatments with them. A lot of providers are still of the mindset of if we just wait, things will start to resolve and then we'll get them on a return to sport protocol. But it's super important that we are using a multimodal approach. We're not just focusing on just one system, but considering all systems, and then using multiple different assessment tools, like other resources, like other clinicians, and just being as comprehensive as we can with this. So some of these things that tend to really help, I want to make sure that they're all individualized and that we are addressing different areas of their function. So CBT is usually pretty good for emotional behavior issues. Aerobic exercise program is good for dysautonomia. And then targeted physical therapy program can be good for also dysautonomia or vestibulo-ocular issues, balance issues, or cervicogenic dysfunction as well. Sometimes with so much going on, it's hard to figure out what the heck do I do with this patient today. But if you know, all right, we've taken care of all of the things in the cervicogenic bucket, now let's start addressing their dysautonomia or their response to exercise. It just helps keep things organized in your mind. Vestibulo-ocular motor screen, super important because I think on the future statements, it's going to be one of the core pieces of it. What those are, you guys are all experts in this, so I'm not even highlight these, but we're just making sure that we're going through saccades, smooth pursuits, and then near-port convergence, vestibulo-ocular reflexes, and dual motion sensitivity as well. And so all this study is saying is that not only is a VOMS assessment safe to do, but it will give us some additional information that we can use, and it's likely going to be within the next concussion consensus statement. When we're in the clinic at Duke, we tend to use a modified version of this using a bike. So I'm going to just tell you what this is. It's the Buffalo concussion test. I believe you guys have learned about it, but there's a very systematic, stepwise way to increase the difficulty on this, and you're basically increasing the speed or the incline, and you're trying to find out what their threshold of activity is. And I'm now seeing that a picture is covering up some of the words on there, so I'll correct that before I send these slides to you guys. But basically, you're trying to determine what amount of activity can they tolerate before their symptoms go off the chart, or before their heart rate starts going higher than what it needs to go. And this helps a new target heart rate for their exercise or a new maximum heart rate for their subsequent exercises. And again, I'm not going to belabor this. You ideally want to continue until you see an increase in symptoms of 2 points or more. And again, this will help tell the new heart rate threshold. And then you're going to want to make sure that they're exercising below that heart rate threshold. So I'm going to talk a little bit about exercising with some symptoms. This is a way of allowing them to still exercise with symptoms, ensuring that you're safe because you're not getting close to that maximum heart rate that we determined with this test. And going to the multimodal approach as well, just ensuring that we're checking multiple different systems and multiple domains within each one of those systems. The Neuro Academy has some awesome resources on there. So if I send you the PDF of these, you can just click on that link, and then there are some really great resources for just different homework, HEP things that you can give them. But super important that we're assessing multiple different areas of balance and not just single leg stance in a static position. Similarly with this, we're actually aiming to make sure that yes, their eyes can move, but are they able to process information? Are they able to move quickly or at an adequate time? Are they able to just respond to light? We just want to make sure that we're doing more than just looking for eye movement with this. And some of the tools that we'll use in the clinic, and I'm sure you guys have used these tools before being neuro PTs, is just this is like a little laser beam that you put on your head, and you're essentially following that maze up there on the left. And so it's a way of kind of ensuring that their cervical muscles are doing what it needs to be doing. Eye movement, you can have them like fixate on one point with their eyes, but then move their head. So there's just different tools that you can use to address and treat these things too. Everything can be an assessment tool if you just track what they had done the previous time and ensure that they're doing a more challenging version or a progressed version the next time. But yeah, these are just treatment methods. And then post-injury management, advocating for early return to physical activity. You definitely don't want to shut them out participation-wise. That's just add to their anxiousness and their desire to get back. Super important that you are on their side and you are trying to get them back into activity, and you're not holding them back, and they're aware of that. So This new idea of a sub-symptom threshold is basically allowing these patients to exercise with symptoms as long as they're not exceeding 7 out of 10 when we're starting the exercise, or greater than a 2-point increase on their symptom score. So what that means, the athlete had a concussion, they are going to get on the treadmill. You're saying, hey, what's your symptoms at? And they say, I just have a headache. And they say it's only a 2 out of 10. They get on the treadmill, they start walking. Now their headache has gone up to 3 out of 10. Well, that's a single point increase on the symptom score. They continue walking, and then now they're starting to see some blurry vision. And so that's another symptom score increase. You can either have an increase in severity of a symptom or a new symptom. Either way, those count as point increases on the score. And anytime we get more than two increases from the baseline symptom, so for this individual, 4 out of 10 would be okay, but if we get any more symptoms, then we need to stop. So this allows them to work out and exercise, and allows them to participate in the activities that they want to participate in, but still being mindful of their concussive symptoms and not getting crazy with how fast we're progressing them. The caveat to all this is if they're at a 7 out of 10, we're not going to even start exercise, or if they're at a 6 out of 10, they're only allowed a single point increase, because once we get to the 7 out of 10, that's the cutoff for overall symptoms. So just be aware of that, and it's super important that we're tracking their heart rate and their blood pressure. A, for the dysautonomia that we had mentioned earlier, are they responding adequately to exercise? And also B, to ensure that we're determining new heart rates if there is any to determine, that we're not exceeding that max heart rate threshold that we had found from the Buffalo test or the bike test, and then we're just progressing at an adequate rate. So this is a return to play concussion progression. There's typically 5 phases, and we're going to have a little bit different ways of doing them, but this is a very general one. And in a perfect world, you would want to do this once they're symptom-free. But if they do have any provocation of symptoms during any of these stages, then we're not going to progress to the next stage. We're going to wait 24 hours, and then we're going to resume with the stage that they were just on. So just to help you decipher what you're even looking at here, we got phase 1, start to the top. Once that looks okay, no symptoms, no increase in severity, everything is good, then we will progress to phase 2 on another date, and then so on and so forth. Typically at phase 4, when they're returning to practice, some institutions want you to have MD clearance, and specifically MD. So just be aware of whatever institution you're working with and their concussion protocol strategy. But this is the general way of doing it. And we do need to incorporate the MD or the specialist that they've been working with when it comes time for clearance. Determining their readiness to return to not only sport, but also just academics or work if they just have a job that's pretty like mentally intensive. You want them to return after about 2 days, and again, that is not shut in the room, that resting and just kind of lower level activity. And then you want to make sure you are kind of in communications with either their work people or their school, and making accommodations for them, and writing good enough notes so that you can determine accommodations that need to be for these individuals. And so typically work and school are going to be on board with that. They're understanding of the situation, and I haven't ran into, fortunately, any places that have been argumentative with any of the accommodations that I've written for my athletes or my general population. Return to academics. So these are just how you can kind of modify things, or just techniques that you can use in the classroom. Put those up there, and then we'll go right on along. And again, different strategies for things that we might be seeing. So if you ask them a question and they didn't really hear what you're saying, or they heard what you were saying, but it took them a second to kind of understand and decipher what you were saying, maybe they're having an issue with their processing speed. We want to make sure that we're addressing that accordingly. Just chart. And again, this is just a generalized chart. You still want to have your own methods of assessing for each of these different domains, and then the accommodations that you would potentially assign when you see deficits in those domains. And then the other thing from the new Amsterdam statement that they did is they changed the wording from persistent symptoms to persisting, So this is to give it in the mind of the athlete. If you think about it, we don't really necessarily want to label them like as you are a persistent symptom patient, because that basically grabs onto their symptoms and kind of makes them almost identify with those symptoms. And I am a patient with persistent symptoms kind of implies that these symptoms are here and they're here to stay. Whereas persisting does the opposite, that are currently persisting, but they're going to go away as we get better. So just a little bit of change in the verbiage. I think it's important that we change this when we're talking to our patients as well, so that they understand that these are temporary and that they will get better. And it's just an important little change they made there. And here's where I mentioned my little systems that I like to kind of use. And so again, it's just that cervicothoracic dysfunction or cervicogenic headaches, or you might just have postural issues or postural correction issues, oculomotor or vestibular dysfunction, in trouble with any eye movements or blurry vision, or there's just many things that you could look at with just that domain as well. And then exercise activity tolerance for that dysautonomia, making sure that we're still continuing to check their vitals and their response to different activities. Super, super important, and I'm seeing this even more now. We coordinate and talk with other providers, not just the MD or not just the neurologist, but also occupational therapists can help a lot. Speech can help with a lot of different things, actually. Like there's a lot of things that a lot of different providers can help out with. Do not be afraid to ask other providers to come in and or at least or send your patient to other providers, because it shouldn't be all on you. It's awesome that we all have the ability to do a lot of this stuff, but it's in your patient's best interest to utilize the resources that are available to them. So do not feel bad about tapping on anyone's shoulder, and I definitely would encourage you to do so. All right, so coming to a close here, just some additional considerations. The Academy of Neurologic Physical Therapy has stated how important hydration and nutrition is. So we want to make sure you're eating a well-balanced diet. It's not in our scope to prescribe certain macros, but we can still tell them how to eat a healthy, balanced diet. You're allowed to tell them they need to eat protein because it is part of their rehab. It's not like you're stepping out of bounds, things that are contributing to them getting better, and that is your job. So don't think, nutrition, I can't do that. That's not in my scope. That's false. Like, it is a part of them getting better. You need to be talking about it. Maybe you're not prescribing 7 grams of this macronutrient every single day. That's not in our scope. But absolutely, you need to be talking about vitamins, ensuring that they're getting adequate food and water as they recover. And that goes for all rehab, in my opinion, to be honest. Another interesting area that's going to be more research coming out in is para-athletes. So just one thing to consider is we don't really know what their baseline is. And if you did do baseline testing, these tests are determined for neurotypical individuals, and so there may be better tests for individuals who have certain cognitive ailments that they're dealing with, or certain disabilities that may affect their line of thinking that may make it difficult to get a baseline from. So just be aware of the fact that, like, you may not be able to ask the same type of questions that you would typically ask, and you may not have a lot to compare it against. There's going to be a lot more evidence that comes out on how to address this patient population specifically in the coming years. So just a couple of the resources that I've used for this presentation. I'm going to continue plugging the Academy of Neurologic PT, but all of these are great resources. And it's really, really important that you just stay up to date on these. The British Journal of Sports Medicine does a really good podcast on all this as well. So if you're a podcast type person, that's a great place to start. But there are so many different resources, and in general, it's just important that you figure out a systematic method of assessing and treating for yourself that aligns with your institution and is effective for your patients. So typically I would go through some questions right now. I'm going to send you all my references, but because this is asynchronous, there's no questions. But feel free to email me. My email is marino, MARINO .Bucci, BUCCI, @duke.edu. I'm happy to answer any questions you might have. And you can always reach out to me in social media as well, too. So you're never bothering me with any questions. I love talking about this stuff. And so I hope you learned something today. And again, if you have any questions whatsoever, please feel free to reach out. and hope you have a great rest of your day. Thanks. Bye.